So I remember finishing the conversation about the heart with the, we talked about the blood flow, kind of knocked this chapter off the list. Now, the next question is, what makes heart contract? And it's cardiac muscle. Okay. So, few things that distinguish cardiac muscle from the skeletal muscle is that first and foremost, cardiac contractions are involuntary. Obviously, you cannot control your heart in the true sense of this word. And cardiac contractions do not require the stimulation, the nervous stimulation. Unlike your skeletal muscles, which contractions can be triggered only by the nerve impulse, heart actually can beat by itself due to the presence of so-called pacemaker cells. And we will get back to this question later on. Cells of the cardiac muscle are striated, which gives away the mechanism of contraction. Striations tell you that cardiomyocytes contain sarcomeres. They branched, which allows cardiac muscle to contract, is more not linear fashion, but more sort of a 3D fashion. They usually have 1 to 2 nuclei. Another important difference of a cardiac muscle from skeletal is that cardiomyocytes are connected by gap junctions. Okay, so here in this schematic, you can see cardiac muscle cells connected by gap junctions. Gap junctions are located into so-called intercalated discs. These are intercalated discs which contain not only gap junctions but also structures called desmosomes. Now, desmosomes are a type of what we call junctions adherence, and their function is to hold cardiomyocytes together. Okay, they sort of kind of elastic, so that allows cardiomyocytes to expand and contract, but the communication between cardiomyocytes is established by gap junctions. Now, gap junctions, as you remember, are basically the ion channels that enable the flow of ions between the cells. Does that make sense? Enabling cardiomyocytes to work as the functional syncytium. Which is important because if you think about it, heart contains millions of cardiac muscle cells. You cannot possibly innervate every muscle cell. So when concentrations of ions, when depolarization happens in one cardiomyocyte, this depolarization can be communicated to another via gap junctions. Does that make sense? Now, there are some structural differences of cardiac muscle cells from skeletal. A lot of mitochondria, well, there are a lot of mitochondria in skeletal muscle, but cardiac muscle is particularly standing out in terms of the number of mitochondria. Now, if you think about the type of metabolism that is required for cardiac muscle contraction, it should be aerobic. Does that make sense to you? Because muscle doesn't produce extremely powerful contractions, but it has to beat each and every second of your life. Okay? So this is a perfect example of slow oxidative fibers. Okay? There's no difference really, but it's the red muscle. A lot of mitochondria. Okay? Sarcoplasmic reticulum is simpler, not as branched compared to skeletal muscle. And endomysium, the connective tissue that surrounds individual cardiac muscle cell, it is connected to the cardiac skeleton, the framework, the connective tissue, and this connection between cardiomyocytes, the cardiac skeleton, allows the muscle, the heart, to contract in a 3D fashion. Of course, since cardiac muscle is red due to the mitochondria, okay, and it carries out oxidative respiration, it requires an extensive blood supply. So cardiac muscle will contain a lot of mitochondria. We're clear. Now the mechanism of contraction of cardiac muscle is similar to that of the skeletal one. And this is a short reminder of the mechanism, cardiac muscle contraction. We're going to start with a discussion of the sliding filament model. Actually, I will go here and we'll address this issue focusing on the sarcomere. So here you can see a fragment of a sarcomere. The M line in the center with thick myosin fibers shown in purple attached to it. The green lines represent thin filament, actin, which is attached to Z discs. When myosin and actin filaments slide against each other, Z discs become closer to the M line, sarcomere shortens, and the cardiac muscle contracts. Are we clear? So this is sort of an expanded view. Here, you see the thick filament that consists of the protein myosin. Myosin has two distinct parts, the heavy tail and the catalytic myosin head. It has two main capacities. It can bind to the protein actin, and it can also break down ATP. Now, protein actin, shown here as the blue beads, each bead is the globular subunit of the protein called G-actin. G stands for globular. Actin forms this long filamentous assemblages that we call thin filaments. And basically the idea of the contraction is that myosin head binds to the actin, and then by moving, myosin head slides the thin filaments in relation to the thick filaments. Does that make sense? Now, two regulatory proteins that control the contraction process are troponin and tropomyosin. You see the yellow string, which represents a protein called troponin. Troponin, in fact, blocks the interaction between myosin and actin, not allowing the complex to form. Sorry, did I say troponin? Yes. I totally misspoke. I apologize for it. It's not troponin, of course. Let me start over. So these yellow beads, these yellow lines here, that's that line and that line, is a protein called tropomyosin. It blocks the binding sites between myosin and actin. Now, tropomyosin is bound to another protein that is called troponin. Here we go. So troponin has a capacity to interact with the calcium ion. When calcium ion, shown here in red, is present, calcium binds to the molecule of troponin. Interaction between calcium and troponin triggers conformational changes in tropomyosin, which shifts away from the binding sites. And at this point, you see these blue depressions. They represent the binding sites between the actin and the myosin. So at the point after calcium bound to the troponin and tropomyosin shifted away, myosin can form a complex with the actin. Okay? Does it make sense? Calcium binds to the troponin. Conformational change shifts tropomyosin away. Binding sites on actin are open. Myosin interacts with those binding sites. Cross-bridge, that's a cross-bridge, is formed. So cross-bridge is a complex between the myosin head and actin. And cross-bridge moves the actin filament along the myosin. We're clear. So this contraction mechanism requires two major factors. It's calcium and, not shown here, ATP. Does that make sense? As long as both are present, cardiac muscle can contract. Okay. So if calcium is pumped back into sarcoplasmic reticulum, contraction can stop. If ATP is not available, contraction will stop. But in the living person, ATP is always available. Does that make sense to you? The mechanism here. We good? Moving on. Now, let's talk about some contractile physiology. We're going to compare skeletal and cardiac muscle. So we're probably going to spend a lot of time in this graphs here. So the graph in the right upper corner, this graph, represents the voltage change in the cardiac muscle cell during the contraction. The black part refers to resting membrane potential of a cardiomyocyte. Does that make sense to you so far? I'm going really, really slow here. We're good? Now, when voltage-gated sodium channels open, muscle cell depolarizes. We clear? Does that make sense? So sodium channels open. At the peak of depolarization, sodium channels are closed. But at this point, the slow voltage-gated calcium channels open. Remember, they are slow. Now, sodium is charged how? Positive. And the concentration of sodium is higher on which side of the cellular membrane? Outside or inside? Outside. So when voltage-gated sodium channels open, sodium flows into the cell, it diffuses into the cell, making the membrane potential more positive. We're clear about it. Now, when sodium channels close, calcium channels open, and calcium keeps flowing into the cell. How is calcium charged? Positive. So that slow influx of calcium maintains depolarization of the cardiac muscle cell. Does that make sense to you? Eventually, nevertheless, membrane potential starts to rapidly decline. Now, why does it start rapidly decline? If you would look at the table, you will see that during plateau, not only calcium channels are open, but potassium channels are open as well. So, potassium is positively charged ion, which concentration is higher on which side of the membrane? Inside the cell. So while calcium flows in, potassium is flowing out. Does that make sense to you? So during the plateau, calcium flows in, potassium is flowing out. Does that make sense? Now you can say, hold on a second. Why we don't have a rapid repolarization of the cell? Well, calcium carries two charges, and although the channel is slow, two charges is twice as much as one, right? So that balance between calcium influx and potassium efflux allows cell to maintain the plateau for, certain period of time. Eventually, of course, at this point, calcium channels close, and the only channels that are left open are potassium channels, and potassium flows out, repolarizing cardiomyocyte. Does that make sense? We're going to go over it at least a couple times more. Okay? So let's try to do it again. Now, I expect you to tell me a little bit more, okay? So please say it out loud. It doesn't matter if you make a mistake, it's not a big deal. Okay? So let's start with what happens in the beginning. Depolarization story. So there is some source of initial graded potential. It can be gap junction from the adjacent cell. It can be, I don't know, epinephrine interacts with its receptor and opens the adjacent channels. Something starts. Does that make sense? Something starts. That's the black part here. It's a black part. So eventually, that initial small depolarization opens which channels? Speak up. Sodium channels. Good. Sodium channels. How are they gated? Voltage gated channels. And sodium flows where? Into the cell because of what? Its concentrations are higher on the outside. Right? We're good? And influx of positively charged sodium ion leads to what? Depolarization. Now, you may notice depolarization is extremely rapid. What happens to voltage-gated sodium channels here at the peak? They close. Which channels open at the peak? Two. Calcium and potassium. So calcium and potassium channels open. Now, where do these ions flow? Calcium flows into the cell. Potassium flows out of the cell. The net change is basically, well, it's a plateau, but if you would look at the dynamic, it's a slow repolarization, like really slow. Does that make sense? And then at this point, what happens to calcium channels? They shut down. They close. Is there any influx of positive ions into the cell at this point? Not anymore. So the only channels that are left open are potassium channels. Potassium flows out of the cell, leading to its repolarization. Does that make sense? There's probably a reason I pay so much attention to this concept. It's one of the fundamental concepts, and I'm going to ask you about this. So, draw this graph. Now, first, refractory period, just like in the neuron, cardiomyocyte, or any other skeletal muscle. Cardiomyocyte is the refractory period. Remember the story about voltage-gated sodium channels at the peak? They aren't just closed. They are temporarily shut down. Is that understood? Nothing can open them. And that shutdown, during that marked by the purple arrow here, is the time when not another single impulse can initiate another contraction. We call it an absolute refractory period. Why it is so important? Well, why absolute refractory? What was the role of absolute refractory period in the skeletal muscle contraction, and why this role is extremely important in the cardiac muscle contraction? Let me explain how you tackle this kind of question. So if you get a question like this, if somebody says, boy, why this is so important, your first thought should be, okay, if it's so important, what would happen if there will be no refractory period? So again, a lot of contractions that would eventually fuse, and fused contractions produce fused, fancy word, T. There's a disease with the same name. Tetanus. Fused tetanus. Fused tetanus in the muscle is basically a prolonged contracture. It's painful. It may be damaging. But if it's, I don't know, your biceps, you're not going to die from it. If your cardiac muscle goes into the tetanus, you're toast. Does that make sense? So this mechanism ensures that there is no tetanus. There are no tetanic contractions. This mechanism allows the cardiac muscle to maintain sort of rhythmicity of contractions. Does that make sense?
Why it's so hard to treat ventricular fibrillation? Is that what happens?
In the ventricular, that's a great question actually. In the ventricular fibrillation, we didn't touch on that yet, but think about, it's actually a good point that you brought up. We're talking about the contraction of a single muscle, or a single cell. In the ventricular contraction, millions of cardiomyocytes have to contract at the same time. Does that make sense? Well, not all of them at the same time, but in a highly synchronous manner. What happens in the ventricular fibrillation? The starting point becomes so asynchronous that different patches, basically, of the cardiac muscle each contract independently. And it becomes a chaotic contraction which cannot produce a concerted effort to pump the blood out. Does that make sense? So no, it's not a tetanus, not a complete tetanus. It's asynchronicity. And we'll talk about how the paths work. Okay. So far, does that make sense? Now, let's compare skeletal and cardiac. Now, this is a typical action potential for skeletal muscle. It's pretty short. Okay, which means stimulation goes really fast, contraction is really fast. Skeletal muscle contraction is fast. And the muscle is ready to contract again. In the cardiac muscle contraction, action potential lasts much longer, and the contraction lasts for a longer time. which makes a perfect sense. It takes time to squeeze the blood out of the ventricles. Am I clear? So essentially, this plateau, due to the calcium influx, allows to maintain a prolonged contraction, effectively squeezing the blood into the circulation. Are we clear? So this is like really important in terms of the physiology of the heart and in terms of questions on the exam. I will ask you about ionic flow. Basically, ionic flow, when channels close, when channels open, whether it is depolarization, repolarization, which ions at which part. Does that make sense? I will ask you about this. Now, heart contracts, it's not super powerful, but it's repetitive. Basically, it's an endurance exercise. Okay? And since it's endurance exercise, it means that heart has mainly aerobic metabolism. There's very little anaerobic capacity for contraction. The good thing, though, is that cardiac muscle can use a variety of fuel sources. It can use glucose, absolutely. It can use lactic acid. You know, one of my favorite topics. I don't know, those of you who did any kind of athletics, any kind of sport, you may have heard from your coaches, you know, when you're sore next day, oh, that's lactic acid. No. That's not lactic acid. Lactic acid is done in an hour after you finished exercising. Lactic acid is responsible for that burning sensation in your muscles when you work out. Once you're done, in about an hour, lactic acid will be flushed by the blood from all your muscle tissue, and it will be used as the fuel by the liver and the heart. Heart can use fats, heart can use ketone bodies, easy. The most important is that heart needs oxygen all the time. Okay? Now, question, is cardiac muscle perform in anaerobic conditions? Well, for a very short period of time, of course. Think about what happens to coronary blood vessels when the heart contracts. They're squeezed. There's no blood flow through the heart during the systole, during the contraction. Coronary blood vessels are squeezed terribly. But what is going to happen to the cardiac muscle in case of ischemia, in case of myocardial infarction? So ischemia leads to anaerobic respiration. Well, in this case, I should say fermentation, because it is more accurate term. Fermentation in the muscle leads to the production of lactic acid. And lactic acid decreases the pH in the cytoplasm of cardiomyocyte. Decrease in pH automatically leads to the release of calcium from sarcoplasmic reticulum, and excessive calcium causes mitochondrial damage. So far, we're good? Now, if mitochondria are, quote-unquote, broken, they cannot produce ATP, and decreased ATP production leads to the closure of the gap junctions between the cells. And when gap junctions do not connect cardiomyocytes, they become contracting asynchronously. Julia, that's to your question. And asynchronous contraction leads to ventricular fibrillation and potentially death. Does that make sense? Notwithstanding the fact that mitochondrial damage is the first step on the way to apoptosis. So mitochondrial damage eventually leads to the cell death. And remember, cardiomyocytes can only be replaced by connective tissue. They are non-dividing cells. So the result of myocardial infarction is scarring of the heart. And that scar is non-contractile. So contractile capacity of the heart decreases every time it experiences such an attack. Does that make sense? People who are physically larger are at advantage here because they usually have bigger hearts. And the person with a bigger heart that suffers a heart attack might be surprisingly a lower risk because, you know, it affects less percentage. You see what I'm saying? We had some clinical examples. You know, I'm not going to disclose, but one of the buddies of mine experienced that, and doctor said, you know, you have a really, really big heart, physically big heart, which saved you, basically. Any questions? We're good? How can heart maintain its heart rate without a permanent stimulation from the brain? The answer lies in the pacemaker cells. So pacemaker cells are the basically changed cardiomyocytes. The function is not to contract. The function is to set the rhythm. So pacemaker cells have slightly different mechanism of depolarization. And first, I want to highlight this beige fragment here. Okay, so this is a pacemaker potential. Now, these are slow, voltage-gated sodium channels. Does that make sense? They basically they leaky channels. They open at the resting membrane potential. Okay, but they slow. They open, and sodium ions slowly flow into the cell, leading to depolarization. So this is prepotential or pacemaker potential. Does that make sense? When pacemaker potential reaches a threshold, calcium channels open. Not only calcium channels are fast, each calcium ion has double charge. So opening of calcium channels, okay, during depolarization, can you see that? Leads to very, very rapid depolarization of pacemaker cells. And then here at the peak, both calcium and sodium channels close, potassium channels open, and potassium starts to flow out of the cell, repolarizing it. Does that make sense? Once the cell reaches the resting membrane potential, potassium channels close. Calcium channels, they stay closed at this point. But voltage-gated sodium channels open. And the cell starts to depolarize again. Does that make sense? Now let's go over it one more time now with your quotations. Are you going to tell me what's going on? And since all channels are voltage gated, I'm not going to mention gating, okay? I'm just going to use ions in the direction of the flow. Deal? So here, during the pacemaker potential, which ions flow? Only sodium. Slow or fast? Slow. Where? Into the cell. So slow sodium influx facilitates the pacemaker potential. When pacemaker potential reaches threshold, which channels open? Calcium. Fast or slow? Fast. Calcium flows where? Into the cell, causing what? Depolarization. At the peak, right here, calcium channels close, sodium channels close, potassium open, potassium gets out of the cell, leading to repolarization. The cell is completely repolarized. What happens to potassium channels? They close with channels open. Sodium, the whole shtick starts over. You know what's amazing in this? You don't need anything. You don't need any norepinephrine, acetylcholine, any neurotransmitter. You don't need any nervous stimulation. These cells, as long as there are proper concentrations of ions in the extracellular fluid and intracellular fluid, they're going to keep on beating. Does that make sense? And they will kind of communicate by gap junctions with the rest of the cardiac muscle. That's amazing to me. Okay. Does that make sense? And they will set the rhythm. Well, I'm kind of anxious a little bit, but we'll get to the conducting system of a heart and you will see some amazing stuff about pacemaker cells. I'm going to ask you about these potentials and the ionic flow. Am I clear? Cool. So this is the intrinsic conduction system of the heart. Okay. And this, we will discuss this in conjunction with some aspects, clinical aspects related to electrocardiogram or EKG. So it all starts with a node, sinoatrial. Sinoatrial node is located in the right atrium, at the junction basically between superior vena cava and the atrial wall. And sinoatrial wall is the main. Now, unless noted, I'm talking about physiologically healthy, normal heart. Okay? Does that make sense? So, normally, in all of us now, sinoatrial node is the pacemaker. It sets so-called sinus rhythm. Okay, we'll talk a bit about sinus rhythm. Good? So, sinoatrial node will send the impulses around the entire atria. That makes sense? And here's the deal. When I say impulses or signals, it's essentially a signal to depolarize. When the signal goes from sinoatrial node anywhere, it's the signal to depolarize. So when muscle of the atrial wall becomes depolarized, what does it do? It contracts, right? So when signal goes from sinoatrial node wherever, it's a depolarization and contraction of the atrial muscle. Are we clear about it? Good. Eventually, it will reach another node, this time called atrioventricular. The name suggests that this node is located at the border between the atria and the ventricle. It is indeed true, right atrium and right ventricle. Atrioventricular node has specific structural features the small fibers and few gap junctions delay the signal at the sinoatrial node. Does that make sense to you? So basically what's going on, the signal goes from sinoatrial node to AV, SA to AV node, and then it stalls for a little bit here. Just stalls. You know, like you rush a bunch of people through a really narrow door. Does that make sense? And then finally, signal enters the bundle. So AV bundle is right here. Bundle of His or atrioventricular bundle. And then from the atrioventricular bundle, signal goes into the bundle branches, right and left. And from bundle branches, the electrical signal goes into the ventricular walls via the Purkinje fibers. The pathway, is that clear? So SA node, AV node, bundle, branches, Purkinje fibers. So let's talk about some physiological applications of what we learned. First, why it is important for a signal, the electrical signal, to stop at AV node or slow down, be delayed. Ventricles will contract after the atria. Does that make sense? Because think about it, that's electrical signal. It's fast. If there would be no stopover, the entire heart will contract altogether. Does that make sense? So that delay allows ventricles to contract after the atria. I usually represent it this way: atria, ventricles. Okay? There's a pause. You see? Second, it turns out that the only electrical connection between the atria and the ventricles is here. Oh, that's a bad color. Here in the bundle of His. There are no gap junctions connecting cardiomyocytes of atria with cardiomyocytes of ventricles. You understand why? Because then you would have multiple signal flows, signal pathways that would reach different parts of the ventricles, and ventricles would not be able to contract in a synchronous way. Does that make sense? So that is the only path between the atria and the ventricles, and that establishes the synchronicity, the certain order of contraction. Does that make sense to you? You got it? Okay. So first of all, AV node slows down the impulse, and AV bundle is the only way through which atria communicate electrically with ventricles. Now, you may ask, hold on a second. All these fibers, nodes, and blah, 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 what do they consist of? They consist of pacemaker cells. It's all chains of pacemaker cells. Okay? Are we clear? Now, look at this column on the right with inherent rates. So the SA node is a setting pacemaker with inherent rate of, well, let's make it, so normally your heart rate is 60 to 80, right? We're going to chat why it happens. And I cannot just, I'm so anxious, I just want to talk about it now and just get it over. Just like the story. Okay? So 60 to 80, that's your normal heart rate. If for some reason your SA node becomes dysfunctional, which node is going to take over? AV. Now the node that, when AV node takes over, this is called junctional rhythm. Does that make sense? So it's about 40 to 50 bits per minute. Can you survive? Yeah. You're probably not going to be too happy. Yeah, but you're not going to die right away. Okay? If you decide to exercise, then yeah, you have a good chance of dying. But if SA node gets, if you have, it's called SA block. If you have SA block, you're not going to die. Now, what if both SA and AV nodes, or AV node is like totally blocked? Is the conduction going to stop? Not really, no. Remember, all those are pacemaker cells. Your AV bundles, depending on the depth of the damage, Purkinje fibers will take over. In this case, your heart rate is going to be even less, like 40, 30, or 20. What's going to happen to you? If it's Purkinje, you're probably going to die. Well, yeah, you got to get a pacemaker, but if there's no pacemaker inside, you're probably going to die, just because of the lack of blood flow to the brain. Okay? Does that make sense? So basically, pacemaker sets the normal sinus rhythm if your SA node cannot do it for one or another reason. Does that make sense?
You said the SA node and the AV node are both pacemakers?
SA node is normal pacemaker. Like in you and me and everybody in this room, I suppose, I don't know your medical history, but I believe that in all of us, SA node now is the pacemaker. It sets our sinus rhythm. Okay? Now, 60 to 80. Why do we have such a heart rate? Our heart, does it have any kind of innervation? Are there any nerves that go to the heart? Come on. Of course. How else we would regulate its activity? There should be at least like one nerve. Okay. Now it's going to be hard questions. Is this nerve somatic or autonomic? Autonomic. And is heart important? Kind of. What is the most important autonomic nerve? Cranial nerve number 10. Vagus. So branches of the vagus nerve innervate the heart. And it turns out that vagus nerve, normally, your resting state, sends signals to the heart, slowing it down. So now you have, your heart rate is 60, 70, whatever, right? Now, say I tell you, go out in the hole and start running. You're not in the baseline resting level anymore. Does that make sense? So parasympathetic controls start to gradually fade away. Sympathetic start to take over. Vagus nerve is an important part of parasympathetic regulatory system. Are you with me? So what happens when you start running, the signals that go through vagus nerve to your heart start to kind of slow down, fade away, and so on and so forth. Does that make sense? So your vagus nerve doesn't tell your heart slow down, and heart starts to accelerate. It turns out that if you would stop vagal stimulation of the heart, your heart rate can go all the way up to 120 beats per minute without vagal stimulation. Now, disclaimer, I'm not shy to say this, I'm not a clinician. So this is the borrowed story. But it's a great story, I love it. I've never been in that clinic, but it's a story from the person who actually, like Dr. Landis told me the story when he was working in the hospital. They have a patient who underwent heart transplant. The patient is doing fine, and the nurse is coming over to check on this patient. And she checks the heart rate monitor, notices that the patient has a heart rate of 120 beats per minute. She rushes, and other than that, this guy is doing all right. But the heart rate is 120 beats per minute. So she rushes out of the room, gets to Dr. Landis and tells him, hey, we have a patient after the heart transplant. The guy has 120 beats per minute. He says, sure. No, you don't understand. 120 beats per minute has tachycardia. It's fine. No, he's not gonna die. Why does the patient who just got the heart replaced has, instead of normal 60 to 80, it's 120 beats per minute? What do you do prior to putting the new heart? Huh? What do you have? What? You have to take out the old one. And when you take out the old one, what do you cut? Everything, including vagus nerve. And while you can reattach great vessels, okay, you cannot stitch the vagus nerve. So for the patient, this 100, 120 is basically new normal, okay? And it's tachycardia, but heart can adjust to that. It's not something astronomical. Everything else will be adjusted. Cardiac output will be adjusted. You know, so it's, but it just tells you, know your, the reasons why it happens, the mechanism, underlying mechanism. This is why we focus so much on the mechanism. Does that make sense? I will question you on the pathway, the conduction system, and you will get some questions, what's going on. We're going to try and tie together the signal transmission, EKG, and events in the cardiac muscle. So for me, I really feel not super comfortable in these waters because that's borderline medicine and I'm not qualified to teach you. So we're kind of going to work together and figure out the basics, and I'm asking basics, believe me. So EKG measures the change in electrical current through the heart. And that has really important diagnostic implications. So let's see what's going on. Start. No electrical impulse yet. Okay? Good? Now here you can see that SA node sends the signal throughout the atrial muscle. Does that make sense? We're good? So SA node is depolarized. Atrial muscle is depolarized. On EKG, it is reflected as the P wave. When atrial muscle is depolarized, what happens to it? It contracts. Does that make sense? Then you can see here, 3, the entire atrium is depolarized. Okay? This is called PR segment, the little segment right over here. The entire atrium is depolarized. Then, at some point, what's going to happen? So when after depolarization, what happens? repolarization. So it turns out that atrial repolarization and ventricular depolarization kind of overlap, producing a set of waves that is called QRS complex. So at the QRS complex, atrium is repolarized while ventricles start to get depolarized. The signal goes through the AV bundle and bundle branches. You with me so far? And then in that short segment that is called ST segment, that's the moment when the entire myocardium of ventricles, all muscles of the ventricles, are depolarized. Okay? Does that make sense? So that's depolarization of the ventricles. During depolarization of the ventricles, what happens? Contraction. So basically we can say this. So here, kind of jumping a bit ahead, this is the heart relaxed. Atria and ventricles are filled with blood. At this point, last beats of the blood are squeezed from the atria into the ventricles. Does that make sense? Now at this point, ventricles are squeezing the blood out into the great vessels. That's ejection phase. Does that make sense? And here, in the stage number 6, you can see T wave. That's the moment when ventricular repolarization starts. So ventricles start to do what during repolarization? Relax. Yes. So again, together, P wave. Now, what I want to hear depolarization, contraction, repolarization, relaxation. Okay? So P wave corresponds to what? Depolarization of atria and therefore atrial contraction. QRS complex corresponds to repolarization of atria and depolarization of ventricles. Now I want to highlight QRS complex is a start of ventricular depolarization, meaning that atria do what? They relax and ventricles contract. And then ventricles stay contracted throughout the entire ST segment. Okay? And then T wave corresponds to ventricular repolarization and relaxation. We're clear. You have to be able to answer the question like, during P wave, this happens. Now, the segments and the intervals. So there are two segments. Since one of them is only on the picture, I promise there will be no question about it, but I'm telling you. So PR segment here, it's the time when the entire atrium is depolarized. Okay, so this is your PR segment. We're good? ST segment is the time when the entire ventricles, all ventricles, the entire ventricular myocardium is depolarized. We're clear. So segments refer to the time when everything is depolarized. Now, intervals. So PR interval shows you the time from the start of atrial depolarization to the start of ventricular depolarization. And QT interval is the time it takes for an electrical impulse, basically, to go from ventricular depolarization to ventricular repolarization. Essentially, by looking at the PR and QT intervals, you can tell if the speed of the electrical signal is normal or not. Does that make sense? Because if the bundle branches, for instance, are damaged, one kind of reason, okay, it may lead to increased QT interval. Say you have an infection in the heart. Myocardium is damaged, there is an inflammation signal, doesn't go through well. Okay, so you have elevated QT interval. That makes sense? The only three segments and intervals that I may ask you about, these three. PR, ST, QT. PR and QT intervals and ST segments. Does that make sense? We're good? So, the heart rate regulation is pretty straightforward. It's the teeter-totter. You have vagus nerve and sympathetic cardiac nerves. Vagus nerve originates in the medulla oblongata, the so-called cardioinhibitory center. Sympathetic cardiac nerve originates in the spinal cord, in the lateral horn. Now, look, physiologically it's pretty straightforward. Normally at rest, your heart is under which control, sympathetic or parasympathetic? Parasympathetic. So, cardioinhibitory center sends the signals down the vagus nerve, inhibiting both SA and AV nodes. Does that make sense? Now, when you have sympathetic activation, what happens to parasympathetic signals? They go down, right? So there's no more signals going through the vagus nerve. They kind of fade away. And instead of it, signals start to come through the cardiac sympathetic nerve, and this nerve receives the input from cardioacceleratory center. Does that make sense? So say when you have low blood pressure, in response to low blood pressure, which center is going to be activated? Cardioinhibitory or cardioacceleratory? You have low blood pressure. Which one's going to be activated? Acceleratory, right? If you have high blood pressure, which center is going to be activated? Cardioinhibitory. Does that make sense? And you have to remember that cardioinhibitory center is under parasympathetic control. It's a part of parasympathetic nervous system, while cardioacceleratory center is the part of sympathetic. Is that clear? We're going to work more about, baroreceptor reflex and regulation of the heart rate and stuff like that. Now, a few words: tachycardia and bradycardia. Are those diseases? They're not. It's normal. I mean, your normal heart rate is 70. If you go to sleep and you sleep really, really well and you're super relaxed and your heart rate goes down to, 55, and you're not dying, yeah, you do have bradycardia. It's totally all right. Okay? That makes sense? If I'm running down the hallway and my heart rate is 150, do I have tachycardia? Yes, absolutely. Am I going to die? Hopefully not. Okay, so that's, that's normal. Tachycardia during exercise is absolutely normal. And say if I have heart rate of 77. Now, I mean, I know that this stuff measures very off, but, 77. My normal is about 65, 70. Am I tachycardic? Not really, no. That elevation is not really tachycardia. Does that make sense? So it's not, it can be a symptom, or should I say a sign of something. It's not a symptom, it's a sign. Say, sympathetic activation, you're scared, you're stressed. It can be, tachycardia can be a sign of a blood loss. The compensatory mechanism. Fever. You always have higher heart rate when you have fever. Okay? Does that make sense? Bradycardia may result, it may be a result of intensive athletic training. I mean, it's not bradycardia for you. For other people, if you have a heart rate of 45 at rest, that's pretty unusual. We're good? Now, what are the main abnormalities associated with conduction system? The first one is SA block. SA block, what does that mean? What is not getting depolarized? Huh? SA node is not getting depolarized. Which chamber doesn't get depolarized? Atrium, right? So depolarization of atrium is P wave. No depolarization, no P wave. Okay? Does that make sense? That's a typical sign of SA block, no P wave. If, well, we kind of see just a fragment here, but you see the rhythm becomes slower because which node takes over as the pacemaker? AV, and it sets the junctional rhythm. Does that make sense? Now, AV block. So there are several degrees. I'm not going to ask about the degrees. Come on. It's not that serious. Just what happens at the AV block? That AV node is essentially a door. Does that make sense? It's a door. So in the first degree, the door becomes narrower. Okay? So PR interval becomes extended. Okay? It becomes narrower, meaning that, the signal goes through longer time. Atria stay depolarized, the time from atrial depolarization to ventricular depolarization is longer, right? So door is narrower. In the second degree, door sometimes gets closed. Dropped beat. So this P wave right here was generated at the SA node. Atria got depolarized. Does that make sense so far? But it never went through the AV node. So no QRS complex, no T wave. And finally, a third degree block. Door is closed. Shut down. Complete block. All you get is ventricular depolarization. And this ventricular depolarization is set by AV bundle, hopefully not Purkinje fibers. You need a pacemaker. None of those. We get into AFib and VFib. Yeah, because there is no signal coming through. So think about this. SA node. So those are, I suppose, P waves. Okay? SA node keeps sending signals. Does that make sense? Aaron? Yeah. SA node keeps sending signals and atrium depolarized. But the signal does not go through the AV, so ventricles receive their own stimulation. They have their own pacemakers in an AV bundle that set their own rhythm. So in this case, atria, do they contract rhythmically? Yes. Your ventricles, do they contract rhythmically? Sure. Rhythms do not match. But you have two separate rhythms. It's not fibrillation yet. Okay? Yeah.
And the top half of your heart is working completely separate from the bottom half.
Instead of this, well, I don't know if my reflexes will allow me to do this. Instead of this, you're going to have something like this. Okay? So the rhythm at which your atria contract is not, that's what Julia was saying, and thank you very much for actually very good clarification for this. Yeah. So in third degree atria and ventricles, why I'm summing it up? Because this microphone cannot hear you. Okay? So atria contract independently from ventricles. Signal from atria, from SA node, does not go through the AV node, and the pacemaker for the ventricles is AV bundle. Okay? Did I sum it up well? Did I sum it up well? Okay. Thank you very much.
I was a paramedic for 10 years. It's like our bread and butter. I was going to ask you.
Oh yeah.
Yeah.
Every time there is a person who is a paramedic or used to be a paramedic in the class, I feel like a child, because I teach this on like a book and lectures. You saw the stuff in the field, so you know way better. Yeah. Now, ectopic focus. When you have an accidental pacemaker outside of the SA node, it's pretty normal. Okay. So beat is originated prematurely. As far as I know, now I have somebody to consult. No irony here. As far as I know, in ectopic focus is basically normal. If you will take EKG on a healthy person like me now, over 5 minutes, you're going to see ectopic foci in my heart. It's like, because I'm drinking, that's my second quart of coffee. Not quart, sorry. Second pint of coffee today. So I probably have some. Okay. When you have like a bit of arrhythmicity, it's probably ectopic focus. Does that make sense? So that's premature contraction of the atria. Premature contraction originated in a bundle will also be an ectopic focus. Okay? So here you can see that P wave is placed over the QRS complex, basically, because the signal from the bundle can go backwards through the AV node. Okay. Also normal, more or less. Yeah. As it goes down to the ventricles, it becomes more and more concerning, because this is the ventricular premature contraction. But think about this. What's the function of the ventricle? Get the blood out, right? Now, if the ventricle contracts earlier than it should, you have to think, is it just a one case scenario, or we have the whole, the whole story here? There is some risk factor, underlying risk factor, okay? And it can be a concern for the ventricular fibrillation. If it's like, like an orchestra playing in a certain rhythm and somebody misses this rhythm. One time it's okay. I played in an orchestra. I know how annoying it is. And if it happens every so often, other people can get thrown off. if this premature ventricular contraction keeps going on, it can change the rhythmicity of other parts of the ventricle. Okay? Does that make sense? Now, Aaron, to your question, atrial fibrillation. Atria, so you can see basically the peaks for ventricles contracting, and that's it. Does that make sense? Your heart still pumps. I mean, and it's okay. As far as I know, people live with AFib. The pumping capacity is lower, and now it's sort of my piece of cake. Any type of flow disruption increases the chances for thrombotic events. Okay. So
With the AFib, basically what you're seeing is atrial kind of, fibrillating, shaking. And when the ventricles finally depolarize and contract, that's when you see
the spike, yeah.
Whereas complex, okay. The big concern with AFib is going to be blood clots because you have that blood just kind of sitting there. It's not truly being pumped out of it.
It's actually a huge part of cardiovascular research, the link between the mechanics of the flow and thrombosis. Does that make sense? So if the blood flows in the laminar fashion, straight, thrombosis is very unlikely. When it starts to curl in any way, thrombosis can happen. For instance, the majority of plaques are formed at the branches of the blood vessels. Because this is, like if you look at the stream of any sort, when stream splits, all these whirlpools will be around the bends, the angles, all those unevenness. Does that make sense? So any uneven flow increases the chance for thrombosis. It's true for heart, it's true for blood vessels. Julie is absolutely right. Yeah, atrial fibrillation is the risk factor for stroke or myocardial infarction. This is ventricular fibrillation. There's no rhythmicity in contractions at all. Different parts of the ventricle contract. They just
Not that we have to get shocked regularly.
Can you tell what shock does with the heart?
Basically, the idea is you're going to send giant voltage of electricity, way more than what your heart normally puts out. And it's supposed to basically reset.
It stops everything.
Yeah, it stops everything and kind of says, whoop, all right, try and reset yourself.
Now,
It works a lot of the time.
really?
Not so much on VTAC usually.
Okay, well, input from the statistics data side. So first of all, I usually compare VFib to a bunch of third graders chatting in the lunchroom. It's just a noise. There's no concerted expression. And then the defibrillator, I compare it to a lunch lady that walks in and says silence, and everybody shuts up. And then maybe something productive will come out of it. Does that make sense? Now, in terms of the percentage, I listened to a podcast in which ER doctors discussed the percentage of defibrillation efforts that are successful in the movies and in the clinic. In the movies, it ranges from 70 to 90%. In the clinic, it's about, on average, 5%. 5% of patients with ventricular fibrillation are actually brought back to life. So it's much less. Yes.
So I'm do shock someone,
Mhm.
and you have to up the volt. If it doesn't work, is that just because that amount didn't stop the heart, or is that
It's what he said is basically they're yelling silence and everybody stops. Oh, wait, let's get back in line. And then, okay.
But the question that I don't really know the answer to, why do we need to increase the voltage? Well, perhaps if fibrillation continues, then you need to increase the voltage.
they stayed in what we call the shockable rhythm, which is we tag or we dip, keep shocking them after CPR. Generally do CPR around the drugs. They're still in the rhythm. You shock them, try and get them to convert.
Thank you. So we're going to take a break now, and I really